Yeah. So Sarah, should we do some introductions? Is this, we're kind of a mix of new and old faces probably. So, and I'm Eleanor Revelle. I'm the 7th Ward Council member, and I'm working with Councilmember Fleming on this crisis response effort. Angela, you want to introduce yourself?
Sure. I'm Angela Valavanis. I have a business in Evanston called Creative Co-working, and I'm involved with the business sector, representing that here because of my time with the Chamber of Commerce and Downtown Evanston organizations.
Great. Patti?
I'm Patti Capouch, Executive Director of Impact Behavioral Health Partners, and we do housing, employment, clinical services for adults with serious and chronic mental illness.
And Kristen?
Hi, I'm Kristen Kennard. I'm the Deputy Director and Director of Social Work Services at the Moran Center. And the Moran Center provides integrated legal and social work services to youth and young adults to the age of 26 here in Evanston.
Okay. And we also have Chris Voss from the police department. Chris?
Good afternoon, Chris Voss. I'm the director of the 911 Center.
Great. So Sarah, do you want to introduce your team?
All right, sorry, there's some people laughing in the background. I don't know if you can hear that here, but I'm Sarah Fletcher. I am our executive clinical director at Trilogy Behavioral Healthcare. Basically oversee all of our assertive community treatment teams and community support teams across the city. And then Susan is also from Trilogy.
Okay.
Hi, everybody. I'm Susan Doig. I'm the Chief Clinical Officer at Trilogy.
Great. And Dan? I think whoops. We need you. You're muted there.
Sorry, I hit the wrong button.
Okay.
Dan Wasmer, a consultant with Turning Points, standing in for Ann Rainey. Thank you. Good afternoon, everyone.
Great. Thanks. Okay. Well, Sarah and Susan, I know you all have been super busy at Trilogy, getting up to speed on how you're going to implement this really exciting grant that you have to launch a crisis response program. So could you kind of tell us how you're doing and how we can be supportive?
Hi. Yeah, Megan Miller, who is on a much needed vacation this week, has been kind of spearheading the hiring for this new project. And so that has started, and she and our grants manager have visited some other programs that have already kind of got crisis, these 24-hour crises departments up and running. And so I think that's been helpful. So she's, in the process of, she's written the manual, she's got all of her job descriptions done, she's hired a manager, and she's in the process of hiring a director to start this program. So we've got some interviews this week, and we kind of want to start by bringing in kind of the higher level management of this team so that person can kind of help us build. And then some of our staffing will be existing staff, and we'll probably, especially in the beginning, start out with using some of our clinicians and have an on-call model. And then the idea is that we'll be, hiring full-time staff. Kind of the idea is 3 teams that will be the first responders on these calls. So it's going, it's happening, but we're not there yet.
And so where were these other crisis response programs that you were able to connect with to learn more about it? Are they in Illinois or?
Yeah, they went to Thrive, which is in Oak Park. And I think some of the things that they learned from Thrive were around, I think Thrive is using kind of like a call-in center. And so they've contracted with a call-in center who then screens calls and alerts their staff to the call. And I think that is kind of what we're deciding is that's probably the way that we'll go, is contracting with a call center, and then just ensuring that workflow is working well. We've done this in the past. A few years ago, we had a call center contract and did some crisis response, and it worked out pretty well. But it takes time to ensure that the call center knows exactly how to screen people, who to get through, et cetera.
And so how does that interact with, for example, an existing 911 program?
Well, I think at this point, until we have, my understanding is the city of Chicago they've just hired, I think, 4 or 5 mental health professionals to supervise a cohort of 911 staff that they're, doing some additional training with, to ensure that the people who are answering the 911 calls are well trained enough and know how to sort of direct the calls. We aren't sure yet from the state, how quickly we'll be getting calls from 911. Will those go through a call center? But it seems like having some relationship with the call center might be helpful, at least initially.
Mhm. Mhm.
And right now we have a crisis line. We have several crisis lines for our own clients, and then we have an 800 number that we've used for a long time. So we have 24-hour crisis response now. And the number, people call our on-call staff directly 24/7. But this feels, I think we want to have some assurances in place to make sure that we've got 2 people that can respond when we need to, and that those calls are recorded in a more robust way.
But the region that you're going to be covering includes Evanston. That's right?
Yeah. Yes. Yep.
So so we need to get you connected with our 911.
Sure.
as well.
Yep.
Yeah.
Yep. And is the city of Evanston doing any of that similar work to the city of Chicago in terms of retraining or training 911 staff?
I'll turn it over to Chris.
Yeah, thank you. Yeah, we actively train with de-escalation techniques and mental health awareness. As a matter of fact, all of the dispatchers just went through an 8-hour training that I assigned to them last month that the state provides regarding mental health awareness and how to approach those type of calls. So it's a continually thing. We do 24 hours of continuing education every year, and many of those assignments like intersect the mental health aspects of the job. So I think from that end, we're pretty prepared to be able to quickly determine what constitutes a police emergency or a medical emergency, and what would constitute a mental health emergency.
Great.
Go ahead. Yeah, I've been jumping in for questions, but anybody else? Yes, and Susan, go ahead.
I just wanted to add one additional item. Currently, we do have a team who works pretty directly with our local CIT officers, and CIT are the crisis intervention trained officers. That's the 40-hour training on mental health that police officers, a cohort of police officers have. And so we are getting referrals directly from CIT now. And so we're actually doing some kind of co-response with them for some folks that they identify as possibly needing help in the community. And so, we have just direct contact with some of our local officers.
But the program that you're setting up with the grant is not a co-responder model, correct?
No, I think it would be a co-responder model. Yeah.
Okay, because I guess my understanding or our understanding was that it was, that there'd be clinicians going out, responding to these calls, but not with a police officer.
Not necessarily. I mean, we, that could be the case, but it kind of depends on the situation, but we do use CIT officers on a fairly regular basis.
Mhm. With this grant though, would you be looking at doing more responses that would not involve a police officer? Because you're going to be expanding your capacity to respond to crisis calls.
Well, so, for example, our current crisis line. So we have people who call our crisis line and, may require an in-person response, may not. So sure, we, on a regular basis, we would do a screening with someone who doesn't necessarily, there's no police intervention, if it's someone who is known to us or we need to do a referral with, we don't use a co-responder model. But if we're heading into the community with someone who's unknown or someone who's potentially, we just don't know what the situation is, or someone could be potentially a danger to themselves or someone else, then we would use a co-responder model in those instances.
Yeah, well, I think we were thinking that those individuals in that kind of situation would probably not come through to this new crisis response program, because the 911 folks would be able to distinguish between people who do need, where having a police officer would be helpful, and then other cases where that's really not going to be necessary. Chris?
I just wanted to convey that essentially, in a lot of cases, when a mental health situation it reaches the point of a 911 phone call, quite often it's escalated to the point where I could understand a co-responder being necessary in that end. That isn't to say that somebody wouldn't call 911 and say, I'm having suicidal ideations, in which case, as long as we can determine that that person is not a threat to themselves or others, to the best of our abilities, there may not be a co-responder necessary for that. But erring on the side of caution is something that we, or at least I am definitely concerned to making sure that we're covering, the needs of the caller, as well as making sure that we're protecting anybody else who's responding to see them.
Mhm.
I'm sorry, I'm just a little confused. So if you don't mind just trying to figure this out. So you're currently working with CIT trained officers in Evanston, right? Is that right? Or Chicago, were we talking?
Probably more so in Chicago. We do have a relationship with the Evanston police, but our main office is in Rogers Park. And so we have more CIT relationships in Rogers Park.
I got you. Okay. I just was trying to, because I think when this committee, when we started out, we were looking at this co-responder model where it would be calls would come into 911 and then they would sort of triage them to the, and their 911 staff, as Chris said, had gone through, the certain trainings, and they would know which ones then could go to what we had envisioned would be like 2 licensed clinicians and 2 peers that, would team up, 1 clinician and 1 peer and go out and work and try to de-escalate, and then see if that person needed to go to, to the ER or something like that. So I just wasn't sure if you were already working with the CIT officers, like if that circumvented sort of the 911 call that got to you, or like how you got those referrals, you know, so I'm just a little confused about that. So, and that could just be me. So, and if it is, my apologies on that.
I'm confused too.
I can speak to Evanston's side of that. So the general rule of thumb in anything involving that comes in 911 that has a piece of mental health related to it, then we will send a CIT officer to that call. That's pretty much probably what Chicago is doing at this point, but they're looping in Trilogy either after the fact or, you know, in concert with, but we have not as an agency done that at this point. We send a CIT trained officer that's on duty to those calls whenever they're available.
Okay, thank you.
Yeah. I do think where we were headed was that scenario would still be in place because there will be definitely a lot of 911 calls where having a police officer will be really essential. But we were looking to have a different scenario that would take place if the 911 dispatcher felt that a officer was not needed, and that's why our crisis response folks were going to have these, ability to instantaneously communicate with the police department in case they did get to the scene and discover that indeed a police officer would be really necessary. So someone could come as a backup really quickly, but we were looking to have a lot of incidents where it would not be necessary for this, even a CIT trained officer. Committee or Susan?
I'm not quite sure how to
Sure,
answer
right.
that. I mean, I think there could be situations where I don't think we can sort of run every scenario. And of course, we don't want to use, I never want to call 911 unnecessarily. That's not something we ever want to do. And so, but I just, I really don't want to promise something that we're not going to do either. I don't want to say that,
Right.
I'm going to send staff out, if people don't feel safe, that we can't really do either. And so I just, I want to be clear. I think there's a lot of opportunity to, intervene and manage crises with people, and the police don't need to get involved. But I certainly don't want to say that that's never going to happen either.
Mm-hmm.
I mean, we use CIT officers quite a bit because I can't safely transport someone to the hospital often if they're really, somebody who's really ill and not doing well and not willing to go. And that's a big part of what we do at Trilogy is, we work with people with pretty serious mental illness and a lot of co-occurring substance use disorders. And so, when I think of crisis, this is also my sort of skewed view. It's, that's when something like that is happening. And I realize that many 911 calls could be someone who's run out of medication or something simple like that. So, in a more extreme case where we have somebody who's really not doing well, and Chris kind of spoke to this, that, often, with 911, it's probably pretty evident when someone calls that the police might need to be there. And so I think we probably are maybe more on the same page than it seems.
Mm-hmm. Yeah. Committee members, thoughts, Patty?
Yeah, and this ties back to, and I don't mean to be dominating the question, so sorry if I am, but it ties back to, we've had presentations from a couple of different organizations about bringing a living room model to Evanston, which is something that I think we probably all are in agreement would be something that would be really beneficial to the Evanston community. And I was wondering if you could speak to what, and the agencies that have come before us, I think also got the 590 grant and are trying to figure out with the state kind of what that is going to look like. But could you speak to what you guys would envision maybe if we were able to bring a living room to Evanston, and how Trilogy and another agency could work together in terms of crisis services?
We've had some discussion with other organizations in Evanston, peer services and connections for the homeless, and Turning Point in St. Francis. Currently we have a couple of clinicians who are embedded in the St. Francis emergency department, and so we get some referrals from St. Francis of people who are in crisis. And so we've floated around a couple of different ideas. We had talked a few years ago, pre-COVID, about, maybe even using some space at the hospital that is not a part of the ED for people who are having a mental health crisis, show up in the emergency room, and that isn't really the right place for them. And so that, would be kind of a 24-hour model. And that's really more of a triage center, not a living room. Trilogy doesn't have a living room, and, living rooms, I think, are run in many different ways. I don't know if there are 24-hour living room models, but often they're, kind of places that people can go, later in the evening, or they have more flexible hours. They're often peer run. And so it'd be a place where someone who maybe is, at risk of harming themselves could go for a period of time. And so I think it kind of depends on what the need is. If somebody is really in crisis and might have, need some medical attention or medications, that might take kind of a living room plus model. And so I don't know that we weren't talking about doing a living room at Trilogy, though.
Right. Yeah, it was my impression that in fact that 590 grant did not cover something like a living room, that it was really just the crisis team. Oh, maybe Dan has, okay.
Yeah, I'm not sure. Susan, thank you for answering that, but yeah, I'm not positive about that.
Yeah, I can chime in. The
Sure.
590 grants are different from the living room grants. State of Illinois is funding both, but they are two different animals, but that doesn't mean they can't work together. And I would say the living room that Turning Point's currently operating, which is expanding, has expanded its hours and days of the week, although it's not 24/7, is open to anyone who wants to use it, whether they're associated with the Evanston, they come through the Evanston Police, through Trilogy, through peers or connections. Anybody is welcome to use the living room. And I think certainly, no matter who does the first contact, if it's a 911 CIT police officer, or if it's a Trilogy following that up, or even our own agency staff, the living room is an open place to refer to. And I think the hope is that if people learn about the living room, they might go there themselves the next time around, because very often people have needs over time, not just what's happening in the moment, but there might be a need next month or next week or next year. And if they know about the living room, perhaps they'll go there directly. That's the hope, but I think we're building towards that down the road by building collaborations anywhere we can.
And so there's actually state grant money, especially for creating living rooms?
Yes, there has been for about 10 years, but just in FY21, so about a year and a month ago or 2 months ago, they funded 23 across the state of Illinois. That was a big increase. So, and what happened for Turning Point is it was able to go from a part-time operation to 7 days a week with more hours per day, from 12 noon till 8 p.m. So 8 hours, 7 days a week. There's always the hope we can go further, but Our experience tells us those are the high volume periods where you get the most bang for your buck in terms of the grant dollar, the staff dollar, and time. So that's the status right now.
Yeah, great. Angela?
Yeah, I was wondering, Susan, if you could describe what Trilogy is offering right now in terms of mobile response and what you might be doing to increase that with the grant money. Like, what can you offer now versus what do you hope to offer?
Sorry, my computer is very slow today. So we do most of our mobile response during the day right now. So, you know, we are coordinating with CIT for, you know, people who have really urgent needs, and most of that gets done during the day. We do have, like I said, we have a 24-hour crisis line, and that is one single human who is on call 24/7, and most of that is phone response. We do have, we've got several ACT teams across the entire city, and so ACT teams have their own embedded crisis number, so the team responds. I mean, those services are 7 days a week, and so teams respond to their own crises individually. So they may go out and do an in-person intervention on a weekend or, you know, later in the evening. But that's really kind of just for those people who are getting that level of service. And so with the money from the state, we would have what we're envisioning is 2 to 3 person teams who are available 24/7 and can respond in person as needed at any time. And I think built into the grant, there are timeframes around that. I can't remember offhand what our time frame, like the amount of time we're allowed or allotted to respond to, but that's pretty specific in the state grant. So we'll need to, you know, really ramp up our staffing for this to ensure that we've got enough people to respond in person and cover the territory. And I think we're just going to have to kind of start and see what the volume is. I think that's what's kind of been hard to know. How many calls are we going to get per shift? And, you know, what will those calls entail? How much in-person response will we need to do? And then we'll just have to adjust from there.
And do you have crisis team vehicles currently, or do you intend to get any?
I don't know that I think we wrote some money in. So I think we're purchasing vans specifically for this. We do both. I mean, we have employees who drive their own cars for work, and we have agency vans as well.
So yeah, so then this, and I'm just like circling it back to when you first started talking about it. So those 2 to 3 person teams, that would be, hopefully you're expanding the team so that more, you know, there's more people to cover it. And then that is what you're talking about in the beginning, that at least initially would potentially be going through like a separate call center versus, you know, not coming through 911 and being kind of flushed out, but coming through like a contracted call center for those calls, right?
Right. I'm going to turn off my camera in the hopes that I'll be able to hear better.
So what, how can the city of Evanston, how can we partner with you, support, amplify what you're planning to do? What role or roles do you see us potentially playing to help with this?
Well, I think now, you know, data would be helpful. I mean, the program that I spoke about earlier with St. Francis Hospital is really kind of a response to, you know, the number of people that they see in their emergency rooms who have mental health crises, but it's not really often those are not medical crisis, and it really isn't something that someone needs to be in an emergency room for. And so if you have data on the kinds of calls that you're getting, sharing that data with us is kind of, at this point, at the planning stage, is the most helpful piece.
So meaning 911 calls from 911 data?
Yeah, yep.
I'll turn to Chris to see if he's, what we'd be able to provide.
That's a very hard to quantify thing. I mean, you're talking, we handle 90,000 phone calls of 911 and administrative in a given year. The basic information that we record during those calls is not enough to say this one is mental health related, that one's not. Where that's parsed out is based on the response of either the EMTs or the police officers when they get to the location. And as I understand it, work is being done in concert with what you're doing to better track those types of calls to make sure that we have better data for that at this time.
Okay. That would be really helpful.
And so, so right now, Trilogy, you do have, I don't know if you call them living rooms, but you have some kinds of places where, people can go and hang out, and I think you have peer staff at these. Like, it sounds to me kind of like this is going back several conversations ago, several months ago, but I seem to remember, I think maybe Megan talking about you having something that sounds now like a living room setup.
We have a peer-run drop-in center that's open during the day, during the week. But we don't have a living room grant. So Turning Point has a living room. I think Dan can probably speak to this better, but I think that's probably a grant funded program that's separate.
Right. Okay.
Yes, that's correct. And the difference between a living room and a drop-in center is a drop-in center has planned activities for people to come, and they can either just hang out or they could participate in the activities, but it's a place to socialize in the community. Where a living room is usually kept free for a walk-in crisis to provide a quiet space for people to be seen. So it's gonna, if you were to walk into them, you'd see the difference. And the living rooms are pushing out to cover weekends and evenings, whereas, as Susan said, the drop-in centers are weekdays during the day. Is where some of them operate on weekends as well, have some weekend hours too.
And maybe Patti can speak to this, but I think we've also been thinking that there's a really important role for peer support to play in this whole big picture. And so so Susan, can you talk about how, are there going to be peer support people at all in your crisis response teams or
Yeah. Yep. Absolutely. We have a robust peer program. So our drop-in is peer run, and then all of our outreach teams have at least one team member on the team who is an identified peer. And then we have various other programs that are peer led. So yes, that is definitely part of the plan. We wholeheartedly agree that, having a peer as a part of especially this kind of service is really crucial. So I would say, I think I'd say 10 to 12% of our workforce are peers. And so we have about 400 staff. So, you know, it's probably 40, 45 peer employees that we have currently.
Well, my understanding too of the actual of the crisis grant is the staff that we hire to be going out to do all of the work actually all have to be peers. They're like kind of identifying that in maybe a little bit of a different way, but sort of having like a family member with lived experience or kind of experience with suicide and that sort of thing. But that all of the staff that we hire for the crisis grant to be going out are like technically peers. So it'll be almost everybody.
Wow,
Working within that.
that's great.
And I think kind of that question that you asked earlier in terms of like what feels like is kind of missing or would be helpful, I guess, in terms of space. I mean, I think something like a living room could work, but I think there's also just a need for a place for people to go. And I think that's been some of those conversations like with St. Francis and Connections. But and I think conversations we've had before about the sort of after 4:30, there's not really anybody to like respond to needs. And some of those needs are mental health related. Some of them are more related to folks experiencing homelessness, but just kind of that space feels like is something that Trilogy doesn't have, that maybe Evanston as a whole doesn't have. And I wonder about like the intersection of different agencies within Evanston being able to kind of work together to have a space like that that folks could utilize after hours. That maybe isn't as formal as a living room. I think it could be that, but it seems like the living room is a pretty like set model too, and kind of how it works.
Yeah, because I think, Sarah, when we were talking about, you know, when this group started meeting, one of the things that we recognized early on is that, you know, the traditional organization ends their day at 5 o'clock, and then there's really not anything or anywhere for someone to go. So when we were, you know, before all the ARPA money and the grants and all that were coming down, when we were looking at it, we were specifically looking at shifts starting like at 3 o'clock and running till 11 o'clock. You know, that I think is something that is really important. Like, I'm excited to see more money going into crisis care, and I'm hoping that there'll be a living room in Evanston and that there can be these agencies working together. It's that gap that I think all of us want to see from, you know, all the interest on the call, from the business interest, from the social services, from the city, from the police department. We'd all love to figure that piece out, I think.
Yeah. Any other thoughts or questions from the committee? It's really exciting to know that you have this grant money and are, it sounds like you're gearing up pretty quickly. When do you think your teams will be ready to go? Do you have a date in mind, or is it too soon to say?
I think it's hard to know, like in terms of direct service staffing, like what that's going to look like. We do have a couple of interviews this week for the director position, so I'm hoping that will get hired sooner than later. Got 2 good ones, so hopefully one of them works out. And then I think from there, it'll probably take a while for them to kind of finalize things. Although, as Susan said, Megan's been working really hard on it and has gotten a lot done just in terms of manualizing things. But I think some of it we're still sort of waiting to hear back from too, about like what it exactly is going to look like. And at least in Chicago, kind of working with the city, like kind of how they're implementing it also will impact what we do. So I think there's still just a lot of stuff up in there. And I think the hiring for the direct staff going out is just a hard thing to know how long that's going to take.
Yeah. Well, especially you'll be looking to hire really great people, and so will the other grantees. We are all
Exactly. Yep.
Yeah,
that is a big challenge.
That's a huge issue for everybody right now.
It is, absolutely.
Yeah. Yeah. All right. Okay, well, we really appreciate your being with us this afternoon to bring us up to speed on where you are and share your thoughts. And we will continue meeting and talking to, figure out what our role can be in helping to support this crisis response effort. So thank you. Thank you very much.
Thank you.
Sure. Okay,
Thank you.
Thanks.
Thanks, everybody.
and see you team in a couple of weeks.
Okay, perfect. Have a good day, everyone. Thank you.
Okay.
You
All
too.
right.
Bye-bye.